So the idea for this discussion came from, well, it's not very original, guessing what everybody else is kind of dealing with out in the region and what we are dealing with here as well. And actually, most recent conversation came about from one of our infectious disease docs who was telling me about the multiple patients he's treating because of complications related to infections from injecting meth. A lot of these are endocarditis, systemic infections that require up to 6 weeks in the hospital. And, the numbers are growing. About a third to a half of all new Child Protective Services referrals in Yellowstone County are related to meth. And a third of all felonies in Yellowstone County are related to meth. And I'm sure there are other numbers that are equally scary. So, one of the things I did is I reached out, and I'm going to talk about some of the data and treatment approaches that are out there. But there was a paper that came out I think it was actually last year, that talked about one treatment approach. And I called the author to find out, okay, if we were to plop you here in the middle of Montana, what would you do? And how would you start treating this? And this was sort of an expert on meth from UCLA. And so basically what I did is I took some of her ideas, I looked up the research and put it on in this presentation just to give us a starting point for discussion. But what I'll start with is kind of, so here the title, Meth in Montana. We'll start with sort of what happens in the brain and meth, and then some treatment approaches. All right, so everybody remembers their organic chemistry. I remember playing with these things. Not everybody had the pleasure of having organic chemistry, but here you see at the top left methamphetamine and what that molecule looks like, and then some of the related molecules: ephedrine, MDMA, MDPV, amphetamine, pseudoephedrine, mephedrone, and cocaine. But again, this is a psychostimulant, right? And what's interesting in the DSM-5, when you look at diagnosis for let's say if you look up meth use disorder, it actually doesn't exist. It's actually stimulant use disorder. But I think a lot of the literature emphasizes distinguishing between meth and cocaine and other stimulants, because meth, as we'll see in a second, acts differently and has other elements to it that make it perhaps more dangerous and more addicting. So I thought I'd start with a cartoon because that's easier for me. So again, big picture. I'm going to start with sort of big picture, then go into little picture as we move forward. So how meth affects the brain. So number one, right, we feel pleasure when neurons in the reward pathways, which is here, it's originating in what's called the ventral tegmental area of the brain, release dopamine. And those dopamine, the dopamine neurotransmitters are released in different pathways. So again, number two here, emphasize that dopamine in the reward centers is released into the synapse, or the gap between neurons, crosses into the next neuron, binds to receptors, and then provides sort of this reward, the sense of reward. And it mentions here, methamphetamine stimulates the release of excess dopamine, heightening the feeling of pleasure. Okay, so that's kind of the simple version, right? So meth, you think dopamine, and really really activating the reward circuitry of the brain. So again, so remember the monoamine neurotransmitter. So the monoamines are these three: those serotonin, dopamine, and norepinephrine. And the structures are similar enough that that sort of releasing monoamines into the area between two nerve cells, that's similar. And here's an example of what happens in dopamine. So basically what happens is dopamine, like in the other monoamines, are kind of in these vesicles, which are basically just like bubbles at the end of this nerve cell. So the top blob is the end of one nerve cell. The blob below is the next nerve cell. So top blob inside has these bubbles or vesicles full of dopamine. And naturally what happens is we get dopamine release sort of as needed in day-to-day functioning. You get reward from anything, having a cookie, chocolate, or whatever. You'll get some of this released. Now what methamphetamine does, it takes this to a ridiculous level and causes just a rush, a surge of dopamine into that area between these two nerve cells, or these two blobs, right? So one's the end of one nerve cell and the other one's the beginning of a nerve cell. So what methamphetamine does, it hijacks the machinery that's used to slowly release dopamine, and it just dumps dopamine into that area between the nerve cells. And so the second nerve cell now is reading, oh my God, there's so much pleasure here because it has dopamine. It doesn't know where it's coming from. It doesn't care. But now you have this surge of signals into the brain that says, wow, this is awesome. Right, so meth in the brain is a potent sympathetic and CNS activator. CNS, right, central nervous system. It's an analog of amphetamine, like we saw before. The structure is sort of similar. But the difference between meth and amphetamine is that meth is lipophilic, which means it's easily attracted to fat, and if it's sort of fat compounds, fatty acids, that sort of thing, which allows it to cross cell membranes. Okay, so if it's happy sort of in fatty environments, it easily crosses between the blood-brain barrier, from the blood into the blood-brain barrier. And so now it's a lot, the effect on the brain is sort of amplified, and that doesn't happen with amphetamine on its own. So again, meth is different. It's easily crosses the blood-brain barrier, which amphetamine doesn't do. So more about meth in the brain. The peak concentration, if you take it by mouth, is about 3 or 4 hours, right? So 2.6 to 3.6 hours, so 3-4 hours. The mean elimination half-life is about 10 hours with a broad range. IV, the mean elimination half-life is about 12.2 hours, so it's actually the half-life is longer. And just for those of us that might be interested in this, meth is then metabolized to an active metabolite, which is amphetamine, and then inactive metabolites to p-hydroxyamphetamine and norepinephrine. And again, it's oxidized and metabolized in the liver. And it turns out 10% of Caucasians are missing or have a defect in the enzyme that actually burns through methamphetamine, which means they are super sensitive to methamphetamine. In other words, methamphetamine will just hang out in the body because it has nothing there to kind of chew it up and get rid of it. So about 10% of people are sensitive in that way. So again, what happens is what's actually going on. So meth passes rapidly through the blood-brain barrier, then into the monoaminergic terminals, which again just basically means it goes to the nerve cells. Remember those two blobs? It goes into the end of that first neuron. It interacts with vesicular monoamine transporters, which basically the vesicles, again, are those bubbles that are full of these neurotransmitters. They actually go into those bubbles, and then it actually dumps. Number one, it accelerates the rate at which these bubbles release neurotransmitters into that space, and also it releases these neurotransmitters into the cell, which ultimately end up in that space. So and then it hijacks also the transporter that sucks it up back in, right? So once these neurotransmitters go into that space, let me just go back, right? So here's the space, right? So once the neurotransmitter goes into space, when it's done doing what it has to do, it gets brought back into the first cell and then repackaged and waits to be released again. But what meth does, it hijacks the machinery inside the cell, and it also hijacks the machinery that sucks the neurotransmitter back into the cell. So it does sort of this double whammy, whereas cocaine and other stimulants really act on the outer side of the cell, meaning it only hijacks the outside part that brings neurotransmitters back in. So meth, again, so two big differences, right? So meth passes a blood-brain barrier, and it hijacks more machinery in the neuron than other stimulants like cocaine and amphetamine. Okay, so like I was saying, cocaine and methylphenidate blocks plasma membrane transporters that reuptake monoamines. That's basically what I was just saying. Meth redistributes neurotransmitters from these synaptic vesicles, or these bags of neurotransmitters, into the cell. It reverses the transport of these neurotransmitters via the plasma membrane transporters, blocks the activity of those transporters that bring it back in, and then decreases the dopamine transporter expression on cell surface. In other words, bottom line is all you need to know is it hijacks more machinery than cocaine or other stimulants. So some of the things that happen: acute ingestion leads to a surge in newly synthesized monoamines. Again, monoamines are different neurotransmitters. So here's the good, the bad, and the ugly, right? So the good, why do people do it? Well, it's experiences excitation, high alertness, sexual arousal, highly focused attention, motivation, confidence, mood, energy, and decreased appetite. That's what attracts people to this drug. What's the bad? Well, you can hyperexcitation. Excitation can lead to anxiety, restlessness, and insomnia. And the really ugly is when it leads to grandiosity, sexual arousal, to a degree that's, pretty bad and leads to really risky behavior. Paranoia, psychosis, hallucinations, delusions of parasitosis. So again, feeling that there are bugs crawling on somebody's skin. That's pretty common. Depression, unprovoked aggression, and violence. What's interesting is meth is incredibly, as you might imagine, but just looking at the literature on this, meth is incredibly toxic to neurons. It's incredibly toxic to nerve cells that causes long-term damage pretty quickly. So within days of steady use, there are biochemical changes in the brain. Number one is you have reduced dopamine transporter function and increased chemical markers that indicate degeneration of the dopamine nerve terminal. Basically what that means is, like I said before, meth hijacks that machinery, especially in nerve cells that work with dopamine. But in addition to hijacking, it leads to long-lasting damage. So you can't, once meth is gone, it doesn't mean it automatically goes back to kind of the way it was before. Steady use over only a couple of days, you start actually interrupting and interfering how that machinery is working. So again, your ability to use dopamine in a natural way is impaired. And here's the comment about that. Monoamine depletion can manifest as exhaustion, depression, lethargy, and anhedonia. Anhedonia is just lack of interest in doing anything you want to do. And like I said, neurotoxicity can occur from as little as several days of meth exposure and may persist for months and even years. So again, the ability to kind of fix what's broken because of several days of meth use can take a long time. Psychotic symptoms are associated with both meth use and meth withdrawal. So you don't just need meth on board to have psychotic symptoms. It can also be in the context of withdrawal. Most meth users within 1 week of continuous use develop auditory hallucinations, delusions of being persecuted, and delusions of reference. And delusions of reference basically just means like you're hearing, you imagine voices coming, or like the TV talking to you, anything happening on a radio is maybe directed at you and that sort of thing. Continued use results in further loss of insight, increased psychoses, and possible violent behavior. Biochemical and structural changes from chronic meth use can lead to significant functional impairment in cognitive processes that persist well into continuous abstinence from meth. And this is, when I looked at some of the literature on treatment, it actually talks about that some of the treatments have to be very mindful of the impairment, the cognitive impairment that meth users have. So they need to, for the lack of better words, or dumb it down and be repetitive because they're cognitively impaired even when the drug is not in their system. So when I was looking at treatment approaches, right? So as we're hearing about all these problems, I'm trying to figure out, okay, do we have anything in our county, in our area, in our community that's actually going after this? And that's when I talked to that Dr. Mooney at UCLA, and I said, okay, what are best practices? For all I know, this is happening everywhere, but I haven't heard about it. So I'm just going to assume that we're not doing this right now. But here's what happened. Early in the 1980s, this matrix model was developed, and I'll talk about that in a second. That's a sort of a psychotherapeutic intervention. And it was initially designed to help treat people who have cocaine dependence and sort of severe cocaine use disorder, let's call it. Over time, got adjusted to work with folks with other stimulant use disorders, including meth. Then, sometime in the early 2000s, they combined the matrix model with contingency management, which basically is providing tangible rewards to patients for showing up, for clean urines. Basically, it's just rewarding certain behaviors, positive reinforcement. And then, more recently, there have been studies trying to look at what other medications might be helpful in treating or helping reduce meth use and address meth cravings. So I'm going to go through some of this stuff. So the matrix model, like I suggested, it was developed in the 1980s at the Matrix Institute in California, and it was used to target folks struggling with severe cocaine or methamphetamine use disorders. The model incorporates elements of different theories, which includes relapse prevention, cognitive behavioral therapy, psychoeducation, family approach, and 12-step programming. It's an intensive outpatient format. So basically what that means, and I think what happens in this program, people show up 3 days a week. I think it's 3 or 4 hours at a time. And you'll see a schedule and a sample schedule here that looks at the time. This sample schedule is looking at the afternoon or evenings when people are out of work. But again, it's an intensive outpatient format with 16 weeks of structured programming, of very structured programming, and then 36 weeks of continuing care. Again, at that point, start trying to maintain any ability to stay clean or to maintain abstinence, let's say. And it includes a weekly urine drug screen, which is done at random at any one of those 3 days. When comparing a matrix model to treatment as usual, that's what TAU is, treatment as usual, across 8 different sites in a study that was called the Methamphetamine Treatment Project, it showed that folks in the matrix model were 38% more likely to stay in treatment. They did this across 8 different sites, different states, including California, Hawaii, I think Oregon, actually Montana, believe it or not. This is back in 2002. And I think actually this part of the study, the one that was done in Montana, was done at the Mental Health Center here with a researcher from MSU Billings. Anyway, across those sites, they had 978 participants with about 82% completing discharge interviews and 86% completing a 6-month follow-up. On average, they were pretty heavy users, 7.5 years of lifetime meth use and 11.5 days of use in the last 30 days. 65% of those chose smoking as a primary way of using, 24% IV injection, and 11% snorting. So what's interesting about the outcomes for the matrix model, so let's look at this. You see here on the y-axis, sort of up and down there, you see the mean number of methamphetamine-free urines at different treatment lengths. One is, site number 1 had an 8-week treatment length. There was 2 sites that had a 16-week treatment length, and the rest were 12 weeks. And so what they did is they compared, okay, how did treatment as usual look versus the matrix model at these 12-week sites? And they found a statistically significant difference in the number of methamphetamine-free urines that favored the matrix model. Okay, again, it's a huge difference. Look at this, it's 4.3 versus 3.3. It's not massive, but it's statistically significant. Next, they looked at comparing the mean number of days of methamphetamine use at baseline. So when they started the study, right? So you see the white bar there is, for those entering the matrix model, was 11.3 days, and those entering treatment as usual was 11.8 days. And then at discharge and 6-month follow-up, there was no difference between the matrix model and treatment as usual. Now, what was treatment as usual? Treatment as usual for all these other sites were still pretty intensive, 8, 12, and 16-week treatment programs, often an intensive outpatient type setting. So what they found was both were helpful. And you'll see here, right? I mean, the numbers dropped from 11 days to about 4 days of meth use in a 30-day period. But so some people would say, well, gosh, this is a failed study because, you know, at the end, a discharge and a 6-month follow-up, there's no big difference. So they were talking about the following. Number one, in the middle of the study, right? Look back here at this slide. During the study, the number of methamphetamine-free urines was better, slightly better in the matrix model. And there were a couple other, let me see if I put it here. No, there were a couple other findings that showed during the course of treatment, people were more likely to be adherent in the matrix model, were more likely to be adherent to treatment, show up more, less likely to leave early. And so the theory is, well, gosh, often, so methamphetamine use disorder is a chronic problem. It's not necessarily something you just assume, well, you're done with treatment, you're cured. It's a chronic problem. So the idea that matrix model might be more helpful and maintain adherence to treatment, participation in treatment, I think has some value and something to look at. Either way, what this shows you, if you're willing to put in the time and effort into a highly structured program that includes some key elements, you're going to get results. So the bottom line is, it's doable, and something can be done to reduce the intensity with which folks use methamphetamines. So what is the matrix model? It has the intensive, remember there's an intensive phase and then a continuing care phase. So it includes 3 individual and conjoint family sessions. they mentioned that relationship with the primary counselor is key. So each person is assigned to one counselor that becomes their primary counselor, and family engagement is key. Then they have 8 sessions of early recovery skills groups, giving them skills to establish abstinence from drugs and alcohol. Then they have 32 relapse prevention group sessions, which is a central component of the matrix model. There's family education group sessions, again, helping families, individuals understand, number one, what is meth? How does it work? Why does it do what it does? And getting families to kind of start breaking down their own feelings around a treatment setting and the fact that their own family members in treatment. And then 36 social support group sessions, which is the continuing care sort of after the intensive session. Here's an example schedule. And so, again, it just lays out in a very well-defined a schedule. And you'll see, you got Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday. You sprinkle in different places. You have the 12 steps. You have the different phases that I was just mentioning before. But this is an example of, you're looking at between 6 p.m. and 8:30 p.m. is when this happens every evening. But people, again, are expected to show up 3 days a week to this. What's nice is the matrix model manuals, because there are several manuals. One is sort of for whoever's like whoever's kind of running the clinic, and then individual counselor manuals. That's all free on SAMHSA's website. So if you just look at matrix model SAMHSA, there's several manuals that are there and can be accessed for free. So like I mentioned to you, the next step in trying to find, to enhance the ability to treat folks with meth use disorder or stimulant use disorder, specifically methamphetamine, was adding contingency management. In this study, they actually used, and so matrix model, even though you look at the matrix model versus treatment as usual, matrix model at this point is considered the gold standard when it comes to sort of psychotherapeutic interventions for meth. So what they did in this study, which I think this study was published in like 2007, 2008, they actually took matrix model alone versus matrix model plus contingency management. And here you see there's a difference. The top bars show you that what are the mean number of samples that were negative for both stimulants and alcohol over the course of treatment. And you'll see with matrix model plus contingency management, it was about, looks like about 13 or 14 versus 9 for treatment as usual, which is just the matrix model. And then the mean weeks of abstinence from methamphetamines, again, a higher number, and they're both statistically significant, higher number of matrix model plus contingency management versus treatment as usual, which is matrix model alone. And there's another graph that tells you what percent of samples were negative for both stimulants and alcohol over the course of treatment. And you'll see the contingency management plus matrix is the red line, and matrix model alone is the blue line right below that. So again, you see a significant difference throughout treatment. And here's a later study that was done, again showing. So here's what this other study did was it looked at contingency management across different lengths of time. So there was standard treatment, which is the bottom line. And again, what does the y-axis show? It shows percentage of patients with negative urine analysis for methamphetamine. The bottom line is matrix. The next line is matrix plus 1 month of contingency management. Then one above that is matrix plus 2 months of contingency management. And the last one is matrix plus 4 months. And essentially what they were trying to show is if you extend contingency management, are you getting better results? And the answer is yes. So contingency management is a positive and useful adjunct to the matrix model. Then finally, medications. These aren't the only 2 medications that have been tested. They've tested other medications, including mirtazapine, which is an antidepressant. They've also tested topiramate. And again, you get mixed results. Nothing is as powerful as at this point as buprenorphine for opioid use disorders. But there's some promising studies. And this is one that was published, I think, last year. This is the one I called that researcher about. And so this study was done with high severity meth users who are using meth at least 20 out of 30 days. And they estimated that in severe high severity meth users, placebo response is only about 10%. Right? We know that in mental health, placebo response is pretty high. But if the higher the severity of meth use, the lower the placebo effect because of the link between the use of meth and the reward system. So what this study did is they said, okay, we're going to set a high bar for who is a responder. And that bar for responder was they need to have 75% of methamphetamine negative urine drug screens during the last 4 weeks of the active medication phase. So what they did is this. They took a bunch of patients. They gave them 1 month injectable naltrexone plus daily bupropion, long-acting bupropion or Wellbutrin XL. They did that, and they said, okay, during the last 4 weeks of treatment, which is weeks 5 through 8, we're only going to call somebody a responder if 75% of the urine drug screens are negative. Otherwise, they're not a responder. And so they did that, and they split here the solid line are responders and the dotted line are non-responders. And the difference for the people who are responders, as you can see, is pretty significant. So on the y-axis, you have the percentage of methamphetamine negative urine drug screens. For the responders and non-responders are the dotted line. Turns out that overall 24% of, and this study was, it was 49 people. 24% showed a response rate, a response, and 33% of those who actually were adherent to medications responded. So a third responded, and you compare that to placebo, which is 10%. That means your number needed to treat is about 5. So, which is not bad. Is something as severe as, here you have a severe meth use disorder. So, again, this is promising. So that's the end of the slide presentation. But again, what I'm imagining is, and this is sort of what the UCLA researcher was implying was, if you start to add up the different tools we have in our toolbox, which is you have the matrix model plus contingency management plus some of the medications, you might start getting better responses. But the point is, I guess